Welcome to Avisena's webinar entitled Evaluation and Management Modifiers. The purpose of this webinar is to explain the CPT evaluation and management modifiers and their importance in receiving the correct reimbursement from payers. And then we're also going to talk about how you identify when and how to use the specific modifiers 24, 25, and 57. At this time, I will introduce Wendy Frierson. She's Avisena's Director of Compliance and Education. Welcome, Wendy.
Good afternoon. I would like to thank everyone for attending today's webinar. So we're going to discuss why do we need modifiers. In today's regulatory environment, it can be a real challenge to obtain reimbursement for procedures and services that are rendered by providers. Accurate coding is the most critical step in the reimbursement process. The use of modifiers are more important every day when reporting claims to Medicare as well as any commercial payers. Modifiers can modify the payment, but also it provides additional information to the payer. Remember, coding CPT modifiers are add-on to your CPT code that signals a change in how your claim should be paid. But most important, remember that your documentation must support appending any modifier. Remember, medical necessity is the driving factor. Now we're going to discuss Modifier 24. Modifier 24 is unrelated evaluation management service by the same physician during the post-op period. Now we'll discuss the usage of Modifier 24. The use of this modifier, the E&M must be unrelated to the surgery but provided within the global care postoperative period. The modifier will be appended to the E&M procedure. Under the Medicare guidelines, it indicates that the evaluation and management services submitted with Modifier 24 must be significantly documented to establish that the visit was unrelated to the surgery, and the diagnosis must support that the claim is unrelated to the initial procedure. The use of the modifier, if documented, indicates that the E&M service performed exclusively for treatment of an underlying condition and not for the postoperative care. And the ICD-9s for critical care, which ranges from CPT code 99291 through 99292, must be supported with diagnosis codes ranging from 800.0 through 959.9, with the exception of 930 through 939. It must be clearly indicated that it is unrelated to the critical care services. Now we have an example of Modifier 24. The first example, the patient has coronary artery bypass. This surgical procedure has a 90-day global period. The patient sees the same physician 30 days after with a complaint of flu-like symptoms. Now, the conclusion is the usage of the modifier on this visit will be appropriate since the flu is not related to the surgery. And the objective of the 24 modifier is the procedure must be unrelated to the post-op period. Now, the second example for Modifier 24. A pain specialist performs a facet nerve destruction for the patient. During the normal postoperative period, the patient returns to the office because of severe knee pain that is totally unrelated to the post-op period. The pain specialist would then report the E&M encounter and append Modifier 24 because the new encounter is unrelated to the post-op period procedure. Now on this slide, we have an example of the CMS 1500 form. Here on this slide, it indicates two procedures. The office visit is combined with the allowable for the surgery. Therefore, separate payment is not allowable during the post-op period. And why? because both procedures are reported with the same diagnosis, which is indicated under Block 24E. So the services are totally related. Therefore, this scenario will not qualify for the 24 modifier. Now in this slide, we have another example of modifier 24 indicated on a CMS 1500 form. And this office visit is unrelated to the surgery, and the modifier 24 may be used. If you look at the first line item, we have 99213 and we have modifier 24 appended. If you look at block 24E, it indicates that it is a different diagnosis from line item 2, which indicates the diagnosis is pointing to indicator 1. So in this scenario, there are two separate diagnoses and they're unrelated. So in this scenario, it would be appropriate to append modifier 24 to the E&M visit. Now we'll discuss modifier 25. It's significant, separately identifiable evaluation management services by the same physician on the same day of another procedure. Now we'll discuss the usage of modifier 25. The purpose of this modifier is to indicate that a significant, separately identifiable E&M service was performed by the same physician on the same day of another procedure due to the patient's condition. The E&M service has to be above and beyond the other service provided in order to qualify for appending the modifier during the postoperative period. So we have surgery guidelines, and it indicates that different diagnoses are not required to report E&M services on the same day. But this modifier must not be used to report an E&M service that resulted in the decision to perform surgery. The E&M service must meet all three components: history, exam, and the medical decision making. And finally, the modifier 25 must only be appended to the E&M code. Now we'll discuss CMS policies regarding modifier 25. A good standard for determining whether the 25 modifier should be used in this: if documented of the patient's clinical record that extra pre-op and or post-op work beyond what is usually performed with the service that was performed, then it will be appropriate to append the modifier 25 to indicate that extra work. You would want to document the extra work that's performed. The clinical record should clearly indicate that extra work or unusual work was performed. The physician must determine if the E&M service for which he or she is billing is distinct from the surgical procedure. And modifier 25 should only be used when a significant, separately identifiable E&M visit is rendered on the same day as a minor surgical procedure. Payment for the preoperative and postoperative visit is included in the payment for these procedures. Now we'll continue with the CMS policy for modifier 25. The policy applies only to minor procedures and endoscopies for which a global period days of 0 to 10 days apply. Significant implies that a great amount of additional work was required. Separately and identifiable. Someone looking at the work would be able to determine what is significant about the amount of additional work that was actually performed. For minor procedures where the decision to perform the minor procedure typically made immediately before the service, the E&M visit is considered to be routine preoperative service and should not be billed in addition to the minor procedure. Now we have an example The patient's office visit is for fever and cough. During the examination, the patient complains of shoulder pain due to severe arthritis, and the physician injects the patient in the joint. The 25 modifier could be added to the E&M visit because there are two procedures that are separately and identifiable. Now we have another example. A patient has a nosebleed. The physician performs packing of the nose in the office, which stops the bleeding. At the same time, the physician then evaluates the patient for the moderate hypertension that was not well controlled, and he adjusted the antihypertensive medication. So in this situation, we would append the modifier 25 because the patient presented for a nosebleed. However, the physician performed an evaluation to manage the patient's hypertension, which may have been the cause of the nosebleed. So therefore, these are two separate and identifiable procedures. Therefore, it would be appropriate to append the modifier 25 to this case scenario. Modifier 25. Now we have example 3. A patient presents to the physician's office with symptoms of urinary retention. The physician performs a thorough E&M service and decides to perform a cystourethropy. This procedure is performed the same day as the E&M code. The conclusion: the 25 modifier may be reported with the appropriate E&M level. In addition to the cystourethropy, the physician had to evaluate the patient based on the symptoms and decided to perform the procedure. The procedure was performed on the same day as the E&M, therefore it meets the requirement of appending modifier 25. Now we have another example of modifier 25. Example 4. An established patient presents with a laceration on the right index finger. While there, the patient asks the physician to evaluate the swelling of the left leg and ankle, and an expanded problem-focused history and a physical exam with a low medical decision-making was performed for this problem. So in this case, we would bill the 1200 with a diagnosis of 883.0 open wound to the finger, and we would also bill procedure code 99213, and we would append the modifier 25 with a diagnosis of 719.0 effusion of the joint and open wound of the finger. So in this case, we would be able to append the modifier 25 appropriately, because again, both procedures are separately and identifiable. Now we have another example of modifier 25. Example 5. An established patient visits her internist to follow up for her hypertension and her diabetes. The patient also complains of knee pain, so the provider did a problem-focused history, an exam, and a medical decision-making. Also, the provider decided to evaluate the knee and determined that the patient would benefit from arthrocentesis. So the provider injected the patient in the site. In this scenario, it would be appropriate to bill the 99212, append modifier 25, and also bill the 20610 for the arthrocentesis. Now we have another example of modifier 25. Example 6. The Medicare patient presents with complaints of left knee pain. The physician evaluates the knee and determined that the patient would benefit from the arthrocentesis. The physician gives the patient an injection and schedules the patient for a follow-up visit in 1 month. Now, under this scenario, it will not be appropriate to bill the E&M visit along with the arthrocentesis, since the purpose of the visit was really to evaluate the patient's knee, and the 3 components of the E&M was not actually provided. So in this case, you would only bill the 20610 for the arthrocentesis. So in this scenario, it would not be appropriate to bill an E&M visit nor append modifier 25. Now we will discuss modifier 25 and the injection services along with E&M services. There are 3 separate categories for injection services. We have our hydration services, we have our therapeutic and diagnostic injections, and our intravenous infusion and other hydration therapies, as well as chemotherapy. The E&M services are considered a part of the injection procedure unless the situation meets the definition of modifier 25. Providers, before appending modifier 25 to your E&M services when an injection is performed, make sure that your documentation meets the definition of modifier 25. Now we'll talk about the inappropriate use of modifier 25, and I would like to add that modifier 25 is one of the most abused modifiers within the Medicare system, along with the modifier 59. I would like to discuss the following false statements. We're going to start with, I can always use this modifier with a new patient. I can always use this modifier when I do not plan the procedure. I can always use this modifier when the diagnoses are different, and I can never use this modifier when the diagnoses are the same. So I would like to re-emphasize, when using modifier 25, significant means that you are performing a great amount of additional work. Separately and identifiable indicates someone looking at your documentation will be able to determine the additional work you perform. If your documentation does not meet the definition of the modifier 25, then we recommend not appending the modifier 25. Now we'll discuss the definition of modifier 57, an evaluation and management services that resulted in the initial decision to perform a major procedure. A major procedure is a procedure with a 90-day global period. Modifier 57 usage. This modifier is used when the decision for surgery is made the day of or the day prior to performing the major procedure. The modifier indicates to the payer that the additional time and effort was necessary and all necessary counseling, including risk and outcomes, were discussed with the patient. Modifier 57 is appended to the appropriate E&M level. Modifier 57 cannot be appended to any other code other than the E&M code. There is no increased fee for the use of this modifier. However, when appending the 57 modifier to your E&M procedure, your E&M procedure will be paid separately and not be considered a global component of the surgery. So, providers, if you're going to append the modifier 57, it needs to be the day before or the day of the major procedure. We have 2 additional requirements for the appropriate use of modifier 57. The clinical information requirement. Medical records are not required to be submitted with the claim, but they must be available upon request. Your documentation must establish that the decision for surgery was made during a specific visit. Now we'll discuss modifier 57 and the decision for surgery made within a global period. E&M service on the same day before a major surgery or on the day of a major surgery that result in the initial decision to perform surgery are not included in the global surgery payment for the major procedures. Therefore, these procedures are paid separately. In addition, the CPT E&M code would need to have modifier 57 appended in order to identify that this visit is a result of the initial decision to perform surgery. If the E&M service occur on the day of the surgery, then the physician will bill using modifier 57 and not modifier 25. Global surgery packages. The global surgery combines reimbursement for a surgical procedure or certain costs associated with the surgical procedure into one fee. Under the global packet, minor endoscopy procedures have 0 to 10-day global period with no preoperative period. Major procedures have a 90-day global period. This period begins the day prior to the procedure and remain in effect 90 days following the procedure. Now we have an example of modifier 57. Our first example is the patient presents with severe abdominal pain. It is decided during the examination that the patient needs immediate major surgery today. The doctor can bill the E&M service and append modifier 57 and also bill the major surgery on the same day, and both procedures will be paid. Example 2. A patient well known to the cardiologist with CAD was seen for the patient's annual visit. The patient had not seen the cardiologist for the past year. After performing a comprehensive history, a detailed examination, the cardiologist determined that the patient would benefit from a valve replacement and scheduled the patient for surgery the following day. The patient is counseled for 15 minutes regarding the treatment options, risk, and projected outcome. The procedure was planned with the vulvoplasty and the mitral valve with a cardiopulmonary bypass. The conclusion is the CPT code 99214 would be billed with modifier 57 appended. Now we would like to summarize everything for today's webinar. So how do you stay up to date on your modifiers? Prepare a list for each physician, most common procedures that Medicare and other payers do not pay for. Provide providers with monthly reports on their claims that were denied or reduced because the modifiers were missing or not properly reported. Track modifier creep by watching for changes in how payers handle and reimburse for modifiers. Track the medical records requests due to E&M modifiers.
And that concludes our webinar on evaluation and management modifiers. Thank you for attending.